Hello, and welcome to the Lancet webinar on Bridging the Women's Health Gap, where we'll be talking about addressing sex and gender-based inequalities in medical research and care. My name is Dr. Kate McIntosh, and I'm the Deputy Editor at the Lancet Global Health. I'm excited for the discussions we're going to have today, which have arisen as part of our In Focus topic on women in health. This is a topic which has been and remains a priority area of research for the Lancet journals. Obstetrics and gynecology are, of course, central specialties in women's health. For women, obstetric care is often their main encounter with the health system, and gynecological diseases are both prevalent and impactful. For instance, 10 to 20% of girls and women of reproductive age have endometriosis. More strikingly, it's estimated that 5% of years lost to disability are due to benign, i.e. non-cancerous, gynecological conditions like endometriosis and polycystic ovarian syndrome. This 5% is in stark contrast to the 1% of years lost to disability that are attributable to malaria, TB, and HIV combined, which obviously receive vastly more attention. However, viewing these fields as the sole focus of women's health disregards the multitude of ways that sex and gender influence health across the lifespan. For instance, relative to boys and men, girls and women experience a higher incidence of lots of chronic conditions that affect their quality of life, such as depression and anxiety, irritable bowel syndrome, and low back pain. Although women have a longer life expectancy than men, a large proportion of these years are spent living in ill health. We also know that many health risk factors are not gender neutral in their impact. For instance, girls and women experience higher food insecurity than men, and they suffer a greater burden from lack of easy access to water and sanitation. As the world changes, the higher risks shouldered by women are increasing. Conflict and climate change, the concomitant necessity for migration, puts women at higher risk of gender-based violence, as well as reducing access to much-needed obstetric care and reproductive health care. According to a study in the Lancet Global Health this year on the obstetric transition that countries undergo, some countries are actually regressing in maternal mortality, largely due to decreasing access to safe legal abortion. We need systemic progress, but we don't have the information to improve the situation. There remains a dual knowledge base of health in boys and men versus that in girls and women. Historically, men have been treated as the default human. Women have been viewed as smaller versions of men with the same health risks, symptoms, outcomes of disease, and side effects of medication as those seen in men. Alternately, women have been viewed as substantially more variable and thus complex than men due to their menstrual cycles. Ironically, recent research is indicating the opposite may be true. Either way, women have long been viewed as not worth studying independently of men, and they've been excluded from clinical trials with limited progress towards equitable inclusion during the last few decades. The resulting exclusion of girls and women from study populations has been extremely harmful. We now have a dearth of information on how diseases like cardiovascular disease present in women relative to men and on the safety and effectiveness of drugs and interventions in their bodies. Public health messaging and clinical teaching educate us on symptoms in men, and there are huge data gaps on health conditions that are more prevalent in women and on the harms and benefits of different drugs during pregnancy. Failure to consider women has left information gaps that in some cases have proven fatal to women. None of this is to mention the indispensable role of women in providing healthcare. Women are not just recipients of healthcare, but key providers. They make up the majority of our healthcare staff, including doctors, nurses, community health workers, and carers. But they're often underpaid relative to their male peers and relative to the criticality of the work they do. Undervaluing and deprioritizing women in health agendas is a cultural issue that pervades even the most progressive countries. And the most important next steps to make systemic changes in the ways that women are treated. So I'm thrilled to be hearing from the speakers we have today, who are all pioneering this systemic change, from Professor Anna Langer, who's provoking international organizations to recognize the value that women provide in the health workforce via the Lancet Women in Health Commission, to Professor Quilin Zhang, who will illustrate how improving lifestyles, especially diet, will be the most impactful way we can improve health in women, with Professor Roxana Mehran finishing with the work of the Lancet Commission on Cardiovascular Disease and the strategies that this commission has generated to combat this previously intractable problem of the failure to include women in cardiovascular research. However, I'm first going to hand over to my co-chair, Dr. Helena Wang, who is the Asia Senior Executive Editor at the Lancet, and she will run us through the agenda for the session.
Thank you, Kate, so much. Hello everyone, I'm Helena Wang, the Asia Senior Executive Editor of the Lancet. I'm very excited and honored to join my colleague Kate and other three outstanding speakers in this wonderful webinar. So first of all, let me walk you through the agenda for today's webinar. Our first speaker today is Anna Langer, who will discuss sex and gender key determinants of women and health. Next, Chuiling Zhang, she will present on modifiable factors and the metabolic disorders among women over the life course and across generations. Last but not least, Roxana Maron from Mount Sinai School of Medicine will address how field of interventional cardiology is moving towards improving inclusion of women in clinical trials. After the presentation from our three speakers, we will move into a panel discussion followed by the Q&A sessions. During their presentations, please feel free to leave any questions in the chat box, and we will try to address them in the Q&A session later. So without further ado, I think next there are some housekeeping issues. I would like to kindly remind you how you would like to ask a question. Use the ask a question box on the dashboard. And you can also adjust or minimize any boxes that appear on the webinar dashboard to suit your preference. A link to the on-demand version of the webinar will email to all once the event has been concluded. Once the webinar has ended, you are warmly welcome to complete a 30-second feedback survey so that we can continue to improve our webinar further. Without further ado, let's invite our first speaker. Our first speaker, Anna Langer. She's a professor of the practice of public health from Department of Global Health and Population from Harvard, a T.H. Chan School of Public Health, USA. Over to you, Professor Anna Langer.
Thank you. Thank you for the wonderful introduction, and hello to everyone. I just want to start my intervention by reminding everyone that today is election day in the U.S., an election whose result may have big implications on public health and women, on everybody really in the U.S. and elsewhere, but in particular on public health and women. So let's hope that the outcome of the election favors public health science and the health and well-being of women. So in 2015, we published the Women and Health Lancet Commission report. And in this report, we included the conceptual framework depicted in this slide. Women and health is a concept that refers to the multifaceted pathways through which women and health interact. It moves beyond the traditional focus on sexual and reproductive health to incorporate women's health along the life course, the roles of women as both users and providers of healthcare, and it highlights the potential of synergy between them. In the report, we propose that in the context of dramatic economic, environmental, social, and demographic transitions, women's health reflects a complex epidemiological transition, characterized by overlapping unmet needs in sexual and reproductive health, nutrition, and infectious diseases, and a growing epidemic of chronic and non-communicable diseases. In the report, we also highlight the importance of breaking silos between pre- and post-epidemiological transition areas of focus and stages of women's lives, adopting instead a comprehensive life course approach. This complex situation is not effectively tackled by health systems that are often unresponsive to women's health needs, although such systems rely heavily on women's contributions to healthcare, either paid or unpaid, as members of the healthcare workforce or in their homes and communities. Sex, gender, and stage of life are the key elements of an intersectional approach to women and health. Today, I will briefly discuss the three main domains of this framework: women's health, women as health caregivers, and the interactions between these two constructs, using some concrete examples. Let's look at the health of women first. Endometriosis, as it has already been mentioned, is a common problem that affects an estimated 10% of women of reproductive age globally. It is grounded in biology, in sex, but the way it is addressed is strongly influenced by gender, which is a social construct. As many other health conditions that are exclusive to women, endometriosis receives insufficient attention from researchers and healthcare providers. This quote from a recent Lancet editorial clearly describes the problem. Decades of neglect from funding and research has stifled medical innovation, and gender bias and sexism prevent women from receiving optimal care. Menstrual pain in particular is widely normalized, which, along with taboos on discussing periods and other symptoms such as painful intercourse, means that many women delay seeking medical intervention or never seek it at all. If they do seek help, symptoms are frequently dismissed or belittled. When we look at problems that women share with men, we see a similar pattern. Cardiovascular disease affects women mostly in their post-reproductive years. Their clinical manifestations often differ from men's due to biological reasons, sex, but gender strongly contributes to disparities in care. Women tend to downplay their symptoms and delay seeking treatment, especially when they give priority to the needs of their children or other family members. In emergency care departments, women with chest pain must wait an average of 11 minutes longer to see a doctor or nurse than men who describe similar symptoms. Very often, their symptoms are dismissed as anxiety-related. Women are less likely to receive an electrocardiogram, to be hospitalized, and to be referred for diagnostic tests or to a specialist. Unfortunately, healthcare providers commonly think that cardiovascular disease is a men's health problem and ignore the fact that it is women's top cause of death. Not surprisingly, women who receive treatment, either medication or surgical procedures, tend to have worse outcomes than men do. In our work, we also study women's roles as sources of healthcare. Women are the main source of healthcare in homes and communities and informal health systems, but their work is often not recognized, unsupported, and not adequately remunerated, as women are unpaid or underpaid when compared to their male counterparts. Women's contributions to healthcare represent an invisible subsidy to health systems and societies. In the 2015 report, we estimated the financial value of this subsidy. We did a study that we called Valuing the Invaluable, using data from multiple sources and applying complex methodologies. We estimated, the health economists in our group estimated that the monetary value of women's contributions to the health sector was, that year, $3.1 trillion. That represented 4.8% of the global GDP, half of it paid, half of it unpaid. This amount exceeded the total US and UK health budget, represented 2.9 times the Mexican economy, 20% of the US economy, and each and every woman contributes $1,200 to health annually. Next, let me briefly discuss the overlap between women's roles as users of healthcare and members of health systems, using women in academia as an example. Female researchers are especially interested in women's health and gender disparities as fields of study, but their underrepresentation in research stalls this agenda. In a system that is characterized by intense competition, women face the challenges resulting from lack of supportive policies to allow them to integrate their reproductive and family roles with their professional ones. That leads to fewer opportunities for publication and smaller grants than those their male counterparts for similar studies get. The reasons are unknown, but this is a phenomenon that has been well documented in the US and in the UK. In a system based on publications and grants, that inevitably results in fewer women in leadership positions who can be role models for junior researchers and advance research agendas. Focus on women's health, which ultimately would lead to improvements in women's health. This is a vicious cycle that needs to be transformed into a virtuous one. We made progress since the publication of the 2015 report 9 years ago, but many challenges lie ahead. The women and health concept has been used by international organizations like the World Health Organization, the International Labor Organization, increasing the attention on women in the healthcare workforce. Fields like women's cancers and nutrition have applied the women and health approach successfully, productively. There is growing awareness of the importance of sex, gender, and a life course approach to women's health in research and clinical practice. And evaluating the invaluable study stimulated other similar analyses, some of them more up to date, providing key evidence for academics and policymakers. But multiple challenges that became more urgent in the last decade demand the adaptation of the Women and Health Flexible Framework. I will only mention a few that have already been mentioned during the introduction, most of them. Accelerated climate change, increased number and severity of conflict situations and natural disasters, pandemics and their differential impact on men and women, the unfinished incorporation of sex, gender, and the life course approach as critical determinants of health, and setbacks in progressive agendas, for example, abortion and LGBTQ health. Thank you very much. I'm happy to continue this conversation during the panel and the Q&A sections. Thank you.
Thank you so much. And we'd like to move to the next talk. We're very happy to invite Professor Zhang Cuilin. She's from Global Center for Asian Women's Health, Yong Lu Ling School of Medicine from National University of Singapore. She will give us a talk on modifiable factors and the metabolic disorders among women over life course and across generations. Over to you, Professor Zhang.
Okay. Thank you so much, Helena and Kate, for the invitation and the kind introduction. It is a great pleasure to be part of the webinar. And hello, everyone in the audience. Thanks so much for joining us. And for those who are in the east side of the globe, thank you so much for staying late for the webinar. I know it is quite late over there. I'd like to open my talk by reiterating several key perspectives related to women's health to set the stage for further discussion. So first, women's health is not just about the female reproduction health and fertility. It concerns other health outcomes as well, as just elaborated by Professor Anna. And women's health is not just about diseases. It concerns overall health and well-being. And thirdly, women's health is not just about women. So I was often asked the question, do you care about men's health and children's? So yes, of course, we care. So we start with women's health because women's health can affect the entire family, community, and all. And women are often key influencers in terms of health for family members, especially for their children, the next generation. And lastly, so clinical treatments are important, but from population health perspective, preventive care is critical for improving women's health. And health in this regard, healthy diet and lifestyle are key pillars for prevention and health management over life course and across generations through their impacts on various pathways. So in the interest of time, in the rest of my talk, I'll focus on diet and nutrition. So I'm sure majority of you are familiar with content in this slide. So it is well recognized that diet is important for maintaining health, optimizing nutrition, and preventing diseases. And poor nutrition is a major well-known risk factor for non-communicable diseases, with an estimated 11 million deaths attributable to unhealthy diets worldwide. And in the US, unhealthy diet was identified as the third leading cause of life lost and disability, ranked right after cigarette smoking and high BMI. And you can see from this figure, so actually the top 4 risk factors are all potentially modifiable factors. And also I'd like to share some interesting data. Next. So in a meta-analysis published about a year ago by Norwegian researchers, it was demonstrated that a sustained change from a typical Western diet to the optimal diet since age 20 years would increase life expectancy by more than a decade for women. and that the earlier the dietary changes are initiated in life, and then the larger gain in life expectancy. So optimal nutrition is pivotal not only for the health of women themselves, but also for the next generation. So for instance, data from animal studies demonstrate that maternal poor diet impact the fuels, hormones, and inflammation with powerful effects on multiple systems of fetus, such as vascular, liver, skeletal muscle, brain, and pancreas. And importantly, many of these impacts persist even when offspring are weaned to a healthy diet after birth. And these effects are often accompanied by persistent changes in the infant microbiome and epigenome, and changes in offspring behavior. So to some extent, early nutrition, maternal nutrition, is driving health risks in the next generation. And both under and overnutrition can be harmful. This is in line well, some of you may know that, is in line well with the developed origins of chronic disease hypothesis, so the Doha hypothesis, highlighting the intergenerational impacts of nutrition. So this slide briefly describes details about mechanism behind the intergenerational impacts of undernutrition. I'm not going to get to the details. So next, I'm going to use the diabetes begetting diabetes vicious circle as an example to show how optimizing nutrition and lifestyle factors over life course may potentially help disrupting the vicious circle based on data from large human epidemiological studies. So some of you in the audience may be familiar with this, the diabetes begetting diabetes vicious circle. So briefly, so gestational diabetes, GDM, is a common metabolic complication in pregnancy, affecting up to 20% of all pregnancies. And its impacts can go beyond the pregnancy time window. For instance, their children are at higher risk for childhood obesity and impaired glucose tolerance. And for girls, when they grow up pregnant, they are at increased risk for gestational diabetes. So this composes a vicious circle. And to disrupt the vicious circle, healthy diet and lifestyle have been shown to be effective at different stages over life course. For example, before, during, and after pregnancy. So before pregnancy, based on data from more than 100,000 women, so we examined the association of 4 optimal modifiable factors: healthy diet, regular exercise, healthy weight, and non-cigarette smoking, jointly with the risk of gestational diabetes. And the 4 optimal lifestyle factors in combination were related to more than 40% risk of GDM, and more than 40% risk of gestational diabetes events could have been prevented through these optimal modifiable factors. And after pregnancy, by following women with a history of GDM for more than 20 years, we observed that multiple potentially modifiable factors are related to type 2 diabetes risk among these women at high risk. And the 4 optimal factors in combination were related to more than 90% lower risk of developing type 2 diabetes. And as we all know that, in addition to lifestyle factors, genetic factors play a role in the etiology of type 2 diabetes as well. So we observe that the beneficial modifiable factors can even alleviate high genetic susceptibility of type 2 diabetes. So as shown in these 2 figures, so with the increment of the number of optimal risk factors, modifiable risk factors, the greater risk of type 2 diabetes associated with family history of diabetes and higher genetic score actually diminished. And during pregnancy, similar findings were observed for healthy diet. So healthy diet was related to lower risk for all these 4 common pregnancy complications, including gestational diabetes. And not just for women themselves. So in a meta-analysis of multiple large birth cohorts worldwide, the poor maternal diet during pregnancy was related to increased risk of childhood obesity for the case born from index pregnancies. So taken together, in the interest of time, I'd like to summarize. So key message from my brief presentation are the follows. So healthy diet is important for women's health, maternal and child health, over lifespan and across generations. And maintaining a healthy diet and lifestyle should be a lifelong journey. So what's next? So most of the data so far were based on studies from US or European populations. So certainly more data are warranted in other populations. So for instance, a well-designed study on women's health in Asian population are emerging, but remain limited. Also, the next milestone is a successful implementation and the translation of research findings into practice. So how to make women to change their behavior, to make healthful food choices, and to improve their diet quality are critical. And to develop effective intervention program, we need to consider several dimensions of sustainable nutrition to make sure food and diet is beneficial to health and prevent diseases, and also beneficial to the environment. And at the same time, we want to ask the questions, whether these foods are economically fair, accessible, and affordable. And I would say this is perhaps the most challenging task and really demand multidisciplinary endeavors and commitment and policy support. So in the interest of time, I'd like to stop here, and I'm happy to discuss further in the panel discussion and Q&A session. Thank you all.
Thank you so much for your presentation, Professor Zhang. I like your point, taking the life course perspective towards the women's health. And also you mentioned that nutrition matters a lot to just not diabetes and also cardiovascular diseases. So next, we will invite Professor Roxana Maraham. She will talk about cardiovascular diseases research, actually, how the field of interventional cardiology is moving towards improving inclusion of women in clinical trials. Over to you, Roxana.
Thank you very much, and congratulations to bring this important webinar to the forefront on this historic day in the United States, but also for the world, Election Day, and how women's health matters, its important economic impact, and the important impact with regard to the health of all humans connected to women's health. The field of interventional cardiology has moved tremendously, but perhaps not enough, and we're working very, very hard on this. So let me begin by telling you that we are missing a lot of information with regard to the health of women because women are often excluded from clinical trials. There's been a huge recognition over the last decades, and you see that on this slide, as early as 1962 up until now, to basically say we need to include more women. Unfortunately, women are often excluded, and for many, many reasons, not to mention about the clinical trials that use inclusion criteria that often exclude women, especially women of childbearing ages. We still see huge underrepresentation of women in clinical trials, especially with cardiovascular research. And I will tell you, cardiovascular disease is the #1 cause of death in women across the globe, but also men. It is really important for us to imagine that this underrepresentation of women in clinical trials limits our potential for developing very important and critical sex-specific strategies and recommendations for cardiovascular disease in women. And very importantly, the lack of personalized cardiovascular care for both women and men ultimately leads to disparities in outcomes. Imagining that women are often the underrepresented minorities in clinical trials, not only it could have a negative impact in terms of diluting the treatment effects in men, It also has an unbelievable impact on having absolutely no knowledge with regard to safety and efficacy of devices, drugs, or strategies in treating women with cardiovascular disease. And what we're seeing over the last decades is a flattening of the curve of mortality in terms of reducing mortality in cardiovascular disease, and unfortunately an inflection point of increasing that mortality number in the last few years, and a negative impact on the future. One of the things we have to consider is understanding the participation prevalence ratio of women. This is 740 clinical trials in cardiovascular disease from 2010 to 2017. Any ratio less than 0.8 indicates underrepresentation in relation to disease prevalence in the clinical trials, especially for women. Women are underrepresented in almost every sector except for pulmonary hypertension. Heart failure, acute coronary syndromes, coronary heart disease, stroke, and arrhythmia trials are underrepresented in women. This current White House, under the direction and the big push by Dr. Jill Biden, has launched an initiative for women's health research to deliver concrete recommendations to advance women's health research, a targeted high impact approach, and by engaging scientific, private, and philanthropic communities to bring us all together as one to combat this issue. This is a tremendous opportunity to not only improve women's health, but perhaps improving by regard in helping women to improve their health, improving human health in general. Because as you heard, women are caring for entire communities. I was very fortunate to lead the Lancet Women in Cardiovascular Disease Commission. And there we came up with top 10 recommendations. Our aims were to reduce the global burden of disease by promoting cardiovascular health and improving outcomes of women worldwide, and identifying existing gaps in evidence with cardiovascular research, treatment, access to care and prevention in women, and igniting a global awareness with regard to sex and gender specific disparities in cardiovascular disease, and a springboard for future research. Our overarching goals were to close these knowledge gaps, enhance awareness. As you heard from Professor Langer, awareness continues to decline in terms of cardiovascular disease being the #1 cause of death in women across the globe. We aim to target well-established sex-specific and under-recognized risk factors that are often dismissed because we're women, and strengthening healthcare systems and engaging healthcare professionals. One of our largest and most important recommendations would be strategies to increase proportion of women in clinical trials, because as clinicians, we practice and our guidelines are informed by science and evidence, and that comes through clinical trials. If women are underrepresented, we don't have the clear guidance on how to treat them. So some solutions, some recommendations was to be more inclusive, avoid the upper and lower age limits, and think about including women in their reproductive years in research, because they also need treatment. Exchanging knowledge, educating, recruiting personnel that look like the patients, not just males, but also women and women of color. Sharing experiences of enrolling women in each study, and conducting surveys for motivation for remaining and adhering to a study protocol and being part of the of the mission of delivering evidence. But very importantly, we ask that we should meet women where they are. They're busy. You just heard. They're caring for their parents and their children and their families and their communities. To be part of a clinical trial requires them to be very engaged and come for follow-ups, to get recruited even or to even understand what those clinical trials are about means that we as a clinical community and researchers have to go to where they are. And of course, working with family physicians who care for these patients to inform them about the possibilities and educating them. And then removing barriers with regard to arranging childcare, free transportation, flexible hours, the kinds of things that we've completely dismissed over the last many decades of research. And the strategies were very, very nicely put out there, not just by us, but by others, in really understanding very similarly what we can do by diversifying our sites, our representative staff, the language appropriate cultural literacy and sensitivity that is needed to bring women into clinical trials, community engagement, and of course, diverse investigators. The good news is that there are increasing women leading randomized clinical trials, but are they really? It's a really, really flat slope. I'd like to see this in a much larger way, but we're getting there. We're pushing this out there, and we absolutely need women to lead randomized clinical trials to allow more enrollment of women. There are some positive examples. I think there's no question that we're working to consider sex as a biological variable in the hypothesis and the design of our studies, and especially not just with clinical trials, but also observational data. And you can see some of these coming forward. Back in 2014, for the very first time, we had an all-woman study in interventional cardiology called the SAFE PCI study for women. We used the American College of Cardiology NCDR registry to enhance and allow an easier enrollment of large numbers of women in a randomized clinical trial to answer a very, very critical question of access, meaning a radial access going from your arm or one from the leg for women undergoing PCI. We're very successful in enrolling large numbers of women in a short period of time. But you must know, in order to get safety and efficacy data in the most commonly used device in interventional cardiology, a drug-eluting stent, in women, we had to use 26 randomized trials in an individual patient data meta-analysis to actually prove that, yes, drug-eluting stents have made important impact in women over time, over bare metal stents from first to second generation drug-eluting stents. This should not be the way we conduct ourselves. We should get the answer in the original trial, not just waiting 10 years later to get the answer in women. And of course, the way to do this is to really focus on women and present and perform data and a randomized clinical trial, for example, in women only. Aortic stenosis is a disease of elderly, especially elderly women. And of course, we were able to do this in this large-scale randomized trial between a transcatheter approach from the leg without opening the chest versus a surgical approach of an aortic valve replacement. These data were presented just recently at the European Society of Cardiology, a very important step forward. We can also think about a condition that's more prevalent in women, like a small annulus in aortic stenosis, and then end up with 87% women enrolled. in this randomized study that we published in the New England Journal of Medicine, we found the important benefit of a certain valve type over the other in women with a small annulus. Powered study in women, which I believe will change the guidelines. And then there are trials now that are being conducted and funded by PCORI. Here's one, the RECHARGE study of PCI versus CABG for multivessel disease that excludes white men. These are women and underrepresented minorities that are now being enrolled in this very, very important multivessel disease, one strategy versus the other, large-scale study to evaluate the efficacy of one versus the other, PCI versus CABG in multivessel disease. We also have seen fantastic ways to include women. This is a randomized comparison of multiple arterial grafts for women and men undergoing bypass. This is the ROMA trial that enrolled 3,600 men and only 690 women. And these investigators were smart enough to say, well, we have enough men. Let's cap that enrollment and continue enrolling women to get to the number of 2,000 women, so we have parity and are able to get a representative sample for multiple arterial grafts versus standard of care in men and women. Here's another way that we could do this. This trial is ongoing. We will see these data not until 2027. And we are also...
Sorry to interrupt you, Rosanna. I'm afraid we are running out of time. So could you finish?
I will go through. I will tell you that the concept of sex as a biological variable has to go all the way to the preclinical. This is very, very important in imagining at all stages of research to enhance the translation and improve the outcomes. And I think what we are doing now is setting up specialized care centers for women with a multidisciplinary approach, increasing this in all of the top 30 US site hospitals, and imagining AI and ability to pick up very, very important diseases through these multidisciplinary approach, imagining that a breast mammography could pick up also arterial calcifications indicative of atherosclerotic cardiovascular disease. So in the end, there are so many opportunities to deliver comprehensive care and intervene in a woman's cardiovascular health from early years to reproductive years to the end of life. It's never too late, never too early. Thank you so much for your attention. And I apologize.
No worries, no problem. Thank you so much for such passionate and powerful presentation. We really enjoy it. It's just that we have a time limit, and we will now move to the panel discussion. And I will hand over to my colleague, Kate.
Thank you, Helena. So we're just going to ask our panel a few questions of our own while our listeners submit questions into the Ask a Question box. So hopefully we can get to as many of your questions as possible. In the meantime, to our speakers, we'd love to get your perspectives on a few issues. So my first question is on multimorbidity, i.e. the co-occurrence of at least two chronic conditions within the same individual. So as populations age, we're expecting multimorbidity to become increasingly common in low-income and middle-income countries, mostly through increased incidence of non-communicable diseases, so cardiovascular disease and diabetes being ones that have already been mentioned. So what research or changes in practice or policy do you think are most needed to ensure that women aren't disproportionately affected by multimorbidity? Perhaps Professor Meering can kick us off.
Thank you. Thank you for that really important question, Dr. McIntosh. There's no question that women do have lots of comorbidities, and perhaps with regard to cardiovascular disease, perhaps it's for the fact that there's lack of early detection and early diagnosis and prevention that is absolutely lacking, because young women are made to believe that they are protected because of their estrogen and menstruation, et cetera, and all of the very, very unfortunate lack of exchange of knowledge for these younger women to have evaluation early on and prevention. So we are at the moment have to deal with the comorbidities that are much more prevalent in older women, and especially the women who present to us with cardiovascular disease and often get excluded because of their multitudes of comorbidities. So it's a very, very important question.
Thank you. Maybe Helena, would you like to ask your next question?
Okay, yeah. So my next question, I might ask a professor. I'm very happy that Professor Anna Langer, she mentioned the endometriosis editorial, because I think these endometriosis represent a very good example showing how slow the progress of women's health. So I'd like to learn your input. And actually, this question refers to all the panelists. Why certain areas of women's health have been such a slow progress? What are the major barriers, and how should we address those major barriers? Thank you.
Thank you. Shall I start? Okay. So as you said, endometriosis is a pretty high prevalence condition, and it remains underfunded and under-researched in spite of the cost on women's well-being and health and economical cost for societies. There is a very, very limited understanding of the disease, and there is a high need for innovation in diagnostic and treatment options that are now lacking. For example, the National Institutes of Health in the US only dedicated 0.038% of the 2022 health budget for a condition that affects 6.5 million women in the US alone and over 190 million worldwide. There are many reasons that contribute to this situation. First, it is important to recognize that endometriosis is a complex and poorly understood disease. It's also important that endometriosis only affects women, and we've heard through these presentations today that diseases that only affect women usually get less attention. Societies normalize women's pain and stigma around menstrual issues, as you correctly pointed out in your editorial. And there is a lack of disease awareness among patients, healthcare providers, and the public. And of course, that all leads to limited funding. What could be done to redress the situation? Well, first, identify knowledge gaps and areas of need to improve women's diagnosis, treatment, and access to quality care. Obviously, provide adequate funding for research on the biology of the disease and the development of multidisciplinary approaches for the diagnosis, treatment, and care. Increase education and disease awareness among patients, healthcare providers, and the public to remove stigma, and ultimately increase timely and accurate diagnosis and treatment. Thank you for bringing up this very, very neglected disease.
Thank you so much for the answer. And any else from other panelists?
May I just? Okay. So Dr. Wang and Dr. McIntosh, I think both of you ask really important questions. So I would think like either for cardiovascular disease or maybe for endometriosis. So it reminds us like we really need to take a holistic approach when thinking about addressing women's health problem. Like it's just not just like one disease, one risk factor, one disease. So there are common causes we need to address. For example, like nutrition, lifestyle factors is important for cardiovascular disease, and also for endometriosis. There are increasing evidence to show that nutrition, lifestyle factor could be relevant for lower the risk for endometriosis as well. So I would think like overall a holistic approach for address women's health is really important. So that's a point I'd like to make. The other thing, like when I look at endometriosis data, I was surprised because I'm not an expert for endometriosis. So I found that actually the highest prevalence is among Asian population for endometriosis, based on the recent report from NIH. But interestingly, also maybe ironically, but not much less data available in Asian populations. So I was thinking about like how to address these data gaps. We also need to pay more attention to minority populations or some specific, really vulnerable populations as well. So just some quick points to make.
And I wanted to just add to that with regard to cardiovascular disease. I think we've been underdiagnosing and imagining women as just being small men, frankly, and that is not the case. And I think what we're learning is that over time, women develop plaques differently, they present differently with cardiovascular disease, and we haven't at all taken into account important sex-specific risk factors. If you ask cardiologists, you even ask about pregnancy-related complications and its implications on early atherosclerosis or cardiovascular disease, most are not taking those histories and are not really carrying an understanding about the important sex-specific issues, and especially in the vulnerable women, vulnerable populations from different cultural and important variables that have stress, anxiety, and other things associated with cardiovascular disease that we've never, ever taken into account. And I think these are all new ways for us to imagine caring for women at a very early stage of her life, and then hopefully reducing the global burden.
Thank you very much. Oh, yes, yeah, you go for it.
May I add something to the first question responses? I would like to focus for a minute on low and middle income countries, because most of what we've said so far applies to high income countries only. Why multimorbidity and in general, non-communicable diseases are not receiving the attention they need and require has some clear explanations, I would say. First of all, there is limited awareness. Most policymakers and researchers are still thinking of sexual and reproductive health issues as the only issues that affect women. Well, of course, there is an unfinished agenda there, but the NCDs and multimorbidities are growing very rapidly. Also, weak health systems. I mean, health systems are prepared to tackle to a certain extent with sexual and reproductive health issues and sometimes infectious disease, but not with non-communicable diseases. There is limited budgets and competing priorities, and it's difficult to make decisions about what to support when you have little money to dedicate to public health. Also, we need to work more on providing data and communicating the data effectively to the public, to policymakers, and to researchers about NCDs. Some health sector reforms have been proposed to better link sexual and reproductive health services with NCDs. Gestational diabetes that one of our panelists talked about earlier is the perfect example. There aren't usually links between gestational diabetes and type 2 diabetes later in life. And finally, advocacy and international support. So I think we can contribute to a broader agenda in low and middle income countries that include multimorbidities, but it requires a big effort. Thank you.
Mm-hmm. Great, thank you very much. So I think we've got enough time for the panel discussion. So we're just going to move over to asking sort of specific questions to our presenters from the chat. So Professor Langer, public health interventions and the cost effectiveness calculations determining whether they're worthwhile investments often assume the unpaid labor of typically female health workers like Ashes in India. But as the Women in Health Commission illustrated, this does a huge disservice to the value these women provide. What steps should policymakers take going forward to ensure these women are appropriately rewarded for the work they do?
Thank you for that great question, Kate. Well, in the Lancet Women and Health Commission, we grouped the recommendations we offered into 4 categories. They are all critically important to address the issue you're asking about. Our 4 buckets were value women, compensate women, count women, and be accountable to women. An obvious first step is recognizing women's paid and unpaid contributions as healthcare providers. The economic calculations that we and others did try to raise that awareness among policymakers and others, offering the tools for evidence-based advocacy. But that is certainly not enough. Evidence needs to be accompanied by some deep societal and cultural changes that involve gendered assumptions. Too often, women's contributions to healthcare, especially at home and in the communities, are given for granted. As caregiving is considered an innate role for women, a vocation that does not need a formal recognition or compensation. Furthermore, women must be accounted in the global health workforce. Global data for human resources for healthcare is scarce, and sex disaggregation is even less available. Only with such information we can contribute to meaningful change. What else? Increased awareness and stronger evidence need to be followed by concrete actions at the country and global levels, such as the establishment of institutions and policies to support women's efforts to integrate their professional and personal responsibilities, training and technologies to advance women's careers, and laws to ensure equal compensation for men and women, which show a big gap everywhere. Finally, accountability mechanisms based on valid indicators at national, regional, and global levels are needed. This evidence can be used to track progress, recognize obstacles, identify success stories to learn from, and guide actions to redress the challenges. So those are some ideas about how to redress this situation. Thank you.
Great, thank you. That's a very comprehensive strategy then. Yeah, definitely worthwhile us all reading that commission. So Professor Zhang, one for you. Improvements to the lifestyle factors like healthier diets you mentioned in your talk will also benefit men. So why are women an important and distinct population when we're planning interventions and policies to address modifiable risk factors?
Thank you so much for bringing out this interesting and important question. So why women is so important in terms of improving diet and lifestyle? Because we all know it's really difficult to change behavior, but women play an important role in the society, in the family. So usually, like, because of the unique role of women, so usually they may cook in the family more likely. And then also, like as I mentioned in my talk, the health of women, the diet, lifestyle of women can also have the important impact on the next generation. So this is why I feel like women kind of focus on women can bring us a unique opportunity in terms of improving nutrition and lifestyle. And so on the other hand, so we haven't touched about that. It is like with the increasing aging problem, like worldwide, it's not a problem, like increasing aging worldwide. But you think about women usually live longer, right? In general, like on average, 5 or 7 years old longer than men. So, so this kind of, there is a term about the feminization of aging. So in that regard, so we really have to pay particular attention to women's health, like on that part, not just younger women, reproductive from early life, and also for older women. So for those women, like how to improve nutrition, lifestyle factors, and then this is really another unique issue. And also in that regard, also like women themselves may play an important role in terms of like modifying lifestyle, like for the whole society, for the whole community. So I hope I answer your question in general.
Thank you. Let's pick out one for Professor Merrin. So we know that even in the most gender equitable societies, women's lives don't completely resemble those of men. So women tend to be responsible for more childcare and more household chores, even when they're in full-time employment. So what would you say is the most effective amendment to common trial procedures that can remove some of the barriers and improve female participation in those trials?
Yeah, no, thank you for that. I think those barriers are tremendously important and often overlooked. And in our commission, we did point out some of the very, very important ways to, one, communicate the clinical trial to to women, making sure that you go to where they are, but importantly, provide some important resources so that they can have time in their very, very busy schedule of caring for everyone in the family to also still remain engaged with the trial and the trial procedures. What's really incredible is that we've seen that they're wonderful for their spouses, the men in their family, to make sure that they are meeting the trial procedures. And they are, often we see that men enroll in trials because women are helping them. But women enrollment in the trial there's no one to help them to get to their follow-up visits, etc. So, of course, transportation, food services, childcare, and important, even allowing for telemonitoring or going to their homes is going to be very, very much more effective in making sure that they could meet the trial needs to be able to be followed up properly. We've pointed all of that in the commission, but I think we need to still do better. We're learning as we're coming along, and I think that we will do better in the years to come by doing our best to include them in our clinical trials.
Great, thanks so much. So I'll pass over to Helena to ask some more questions from the questions that we've got from our audience.
Thank you, Kate. Actually, we have lots of questions here. So I'm just trying to pick some questions from the audience. So I think one question regarding to mental health of women actually is quite interesting, because we talk about physical health a lot, talk about physical health like endometriosis, diabetes. But I just want to throw the question to all the panelists here. So how the medical research address the correlations between physical health and the mental health of women, and especially in case condition like endometriosis and the other chronic diseases? What do you think?
I'm happy to take that for cardiovascular disease. We pointed this out in the commission, that stress anxiety has been previously, and there was a study, Interheart study, that showed that stress anxiety is related to inflammation and almost is an important risk factor, same as smoking and diabetes and hypertension. Yet we as clinicians, we don't have enough time, and we're not spending enough effort in understanding the mental health of our patients and where they are, and what kind of stress and anxiety is bestowed upon them. And I think we need to do better. We are calling these the under-recognized risk factors in our commission, and believe that a lot of research needs to be done to further enhance and evaluate an understanding of the contribution of these important risk factors, the psychosocial risk factors, to cardiovascular disease as a neglected one that needs close attention.
Mm-hmm. Okay. May I have a comment related to maternal child health, mental health? Do I have time? Do we have time? Okay. So just briefly comment. Thank you. Just briefly comment like how mental health important have been related to pregnancy complications like maternal health and child health. So like depression is a risk factor for several pregnancy complications, including gestational diabetes, and also depression during pregnancy. Maternal depression has been related to the offspring's mental health, chronic function development as well. Of course, we need more research in that regard. But so from like intergender impact, so from that perspective, the intergender impact of mental health, so this is a really important question to address as well.
If I may add just a quick word about that, I would say that mental health is currently receiving more attention than a few years ago, in great part due to the terrible effects that the COVID pandemic had on mental health, particularly among young people, men and women. but also in other fields. For instance, peripartum depression is currently receiving more attention, and there are now some interesting developments about how to handle it, in addition to efforts to destigmatize the condition. So, of course, there is a huge unfinished agenda on mental health, both linked to biological, sex-related conditions maybe, but also, well, mental health as a separate condition that requires all our attention. So I just wanted to point out that some progress is being made in terms of mental health, and the awareness we currently have about the burden of mental health is rapidly growing.
Thank you all. And I actually have found another question. We have lots of questions from low and middle income countries. So they actually wonder about the funding and the data from low and middle income countries. As you know, there are we have experienced financial difficulty during the past few years. So the government, mainly, they have many other priorities in their mind. So how do we balance all the challenges in the priorities in the political political agenda? So how do we like advance women's health in their political agenda, particularly in the financial hardships? Thank you.
Maybe, I don't know, I can start. I spent most of my career working in low and middle income countries, and saw firsthand the challenges that, policymakers, researchers, women, of course, and the public in general are facing. The resources are certainly limited. It's very, very important to advocate for more resources for public health in general and for women's health in particular, when it comes to priority setting. But also, I think global organizations, global institutions have a responsibility, and it's important to, in particular in the case of research, to support work in low and middle income countries that will clarify the epidemiological situation, and will probably identify innovative solutions that might be context specific. So those strategic investments are definitely necessary. But governments need to do their work too. They need to allocate the resources that are needed to improve the quality of healthcare and to improve access to healthcare. There is no easy answer to that very, very important question. And with climate change happening, and with more and more conflicts jumping everywhere, it's difficult to make sure that the resources that are needed are in place. But we need to keep fighting for that.
Any further comments from the other speakers?
Just maybe like a quick comment, quick details. In the secure limited resources, I would say we have to be creative. So I want to share like one inspiring story I recently learned. Like last year, I learned from a conference I attended in Tunisia. So one of the speakers from Africa, so from a poor village. So she shared like their success story about educating husband. so they have the husband school, and then like they found like educating husband is really helpful in terms of addressing some like basic women's health issue, like the hygiene related to women's health issue, and also food hygiene, all those things. So that kind of, I feel like, so in addition to kind of always focus on women, whether we can be more creative, like using limited resource, think about other potential educational program, like maybe men, on the other hand, can help as well. So that is an interesting story I'd like to share.
Thank you. That's indeed interesting. And if there's no further comments, I actually have another question from the young participants. Who would be interesting to ask, how can young people get involved in tackle women's health? what opportunities are there for young researchers to get involved? Would any one of you like to address this question?
I would love to take that on because I believe that we need our youth to be mobilized, young men and women, and I'm hoping that young men are also interested in women's cardiovascular care or women's health. What I'm seeing is that it's mostly young women or women in general interested in women's health, and it really should be, not. It shouldn't be that way. It really should be all of us interested in this. I think the youth, the young people could have tremendous opportunities in helping, especially for cardiovascular disease. There are a lot of opportunities. Certainly, the American College of Cardiology, European Society of Cardiology, and the American Heart Association is always looking for volunteers who want to serve on these committees and to spread the news and to be part of the mobilization and recognition and awareness of heart disease as the #1 cause of death in men and women across the globe, but also in understanding the sex-specific differences and educating not just the public, but also our colleagues. And furthermore, I think there are tremendous opportunities in research and in funding for younger, for K Awards in the and certainly in the National Institutes of Health, and great opportunities with PCORI grants, et cetera, for younger first-time researchers to focus on women's health. This is a huge initiative by the NHLBI and PCORI. And so there are tremendous opportunities, especially for younger researchers who are interested in the field.
That's very exciting to learn. So any other comments from other panelists?
Yeah. So quick comments, maybe. Yeah. For our center, Global Center for Asian Women's Health, because we are in Singapore, but we're surrounded by low middle income countries. So we always open doors to young researchers through a fellowship or maybe educational program. So we really welcome and like to have those young researchers, young generation, nurture those young generation from surrounding countries as well. So feel free to contact us if. So we are always there, trying to help.
I would only add that well, there are many opportunities for young researchers, but more importantly, I would like to tell the young researchers in the audience that we need you. I think that most of the important solutions to some of the intractable problems that seemingly intractable problems that we are leaving behind will come from you. So it's very, very important that you engage and that you identify those opportunities that my colleagues mentioned here and many more to develop a career on women's health or public health or any related field, because we definitely need your intelligence, your imagination, your ability to innovate, and we are all hopeful that the next generation will find some solutions for the issues that we have in front of us.
Thank you all for your answers. I think I will, as two of the speakers at the beginning talk about today as an election day, actually we have a question from the audience asking about how could the results of these elections impact on women's health? Would you like, any one of you would like to answer this question?
Well, I'm happy to take that on because I just did present in my presentation what the current administration is hoping to do in terms of really focusing on women's health in the next decade. And the funding opportunities are tremendous for research that are sex-specific and specific to women in improving their health in all stages of life and not just in cardiovascular disease. I think the amounts of money that has been sort of touted and put forth on this does depend on who's in the White House, and I think that is an important piece. And certainly we learned over the last, for the very first time, the women's reproductive health is going to be very much affected as well. And I think that is a very, very important one for women around the world, but certainly for women in this country, not having the rights of their own, understanding what they would be doing with their own reproductive health in terms of termination of pregnancy, et cetera, due to whatever the cause is. I think those are really, really important impact for women's health in general altogether, and their mental and mental health as well. So I do believe it will have very, very important impact on women's health. This today is a very, very important day.
I totally agree.
Okay, so if there's no further comments, I'd like to ask the last question today from the audience. I think there's a very interesting question from the audience saying that regarding Professor Zhang's observation, we need a holistic approach. I wonder if part of the challenge is that we end up parsing out women's health than studying women's health in its entirety and interconnectivity. So can CVD be understood independent of women? Yeah, so the question is basically on how can we move out the women's health from the silos? So it's just not women's health, it's cross all the disciplinary as far as I understand. So do any of the speakers have any comments on this point?
Well, I would say I'm happy to just. I mean, Professor Zhang probably should be answering this, but I would say in terms of cardiovascular care for women, it absolutely is an interdisciplinary approach. It has to be, because women aren't seeing cardiologists; they're seeing their OBGYN physicians, and pediatricians are seeing young girls. And so we're not seeing them. And so family practice. And of course, when women are diagnosed with cancer, they're going to oncologists and they're getting their cardiovascular care even cared for by them. So there are fields now coming forward with cardio-obstetrics, cardio-oncology, just bringing the interdisciplinary approach and bringing everyone in. And I believe that the mental health care workers are going to be also very, very important in identifying some of these under-recognized risk factors and thinking about cardiovascular screening. I think at any time there's contact with a woman, there needs to be cardiovascular screening, no matter what your discipline is, because it's the #1 cause of death, because we all have to be in it to win it. And so I believe that this is something that we need to spread around the world.
Thank you so much, Professor Mohan, for the comments. I agree with you. CVD is really important. So the other thing I was thinking of, I was very glad to see, because at the beginning of maybe 10 years ago, like still different field, maybe still in silo, like the OBGY kind of independent from the endocrinologist and also from cardiologists. But now I'm really glad to see, because I'm working on research a lot related to pregnancy health, the long-term implication for women's health and also for the children. So it is really important, like, to regard it like the early life events and also events in women's reproductive age, the long-term health implication for their lifelong health. So I'm really glad to see more and more research and more funding has been devoted for this life course approach and also holistic approach in terms of improving women's health. So I hope like more and more interdisciplinary and transdisciplinary efforts can be done in the future. But I'm really glad to see, like, now cardiologists, they may ask about your pregnancy history, like whether you have preeclampsia, gestational hypertension. And then for those endocrinologists, they ask about the history of diabetes in pregnancy. So I do see the hope, and also I do see the progress in this regard.
If I may add,
yeah, please.
Yeah, a few words about the importance of not only linking conditions across the life course and linking specialties in the field of medicine. It's also important to work multidisciplinary with other industries, other entities. For instance, going back to the example of endometriosis, well, if we want endometriosis to be diagnosed earlier, if we want women to seek help in a more effective way, we need to work with communication specialists, people who would help destigmatize issues surrounding menstruation and other symptoms that women might feel uncomfortable disclosing to their doctors. We may need to take into account other determinants of health that are present in an intersectional approach, the age of women, the socioeconomic level of women. In some societies, the race and ethnicity of women that may also represent challenges for seeking help, care, and for getting the good quality health care that girls and women need. So it's a matter of looking at health not only as a medical issue, but rather in a very comprehensive way across the life course, and well, always linking women's health with a broader well-being.
Yeah, thank you so much. I think we have many more questions to come, but given the time is quite limited, we have to audience. But let me ask every speaker to provide one thing that you want people to take away from the webinar from today. Before we wrap up, so over to every special panelist, what you would like to comment for the one thing take-home message?
I would say focus your interest in whatever field you are currently working in or planning to work in on the health of women and on sex and gender as determinants of health and disease. Adopt a comprehensive approach and help us, well, move that agenda forward.
I'm happy to add mine, and I think I already said it during my talk, that women's health matters. It matters for all of us, and it has an important, huge implication on human health in general. And we can't do it without the collective interdisciplinary approach of everyone coming forth to care for this from the beginning to the end of the life of a woman. They can no longer be ignored, underrecognized, undertreated, underdiagnosed, or misdiagnosed. We absolutely have to do this together as one.
Okay. So I like to refer to some slogan from our center, mission. So we think women's health is a cornerstone for the health and well-being of the community and of the society. And happy, healthy women, happy, healthy family, and happy, healthy society. So that's I like to end with this message.
Thanks so much for the discussion, and I will hand over to my colleague, Kate, to wrap up today's webinar. Over to you, Kate.
Great, thank you, Helena. Thank you all for what I think we can all agree has been an illuminating and engaging discussion. I think there are a few themes that have come out that need more attention. So we need more information on women's health to enable implementation of sustainable interventions that actually reach all women globally. So women in low and middle income countries have been particularly brought out as a priority on our audience Q&A discussion. As Professor Langer said, I think global health organizations need to prioritize those context-specific interventions, and governments need to allocate resources appropriately. And as Professor Marin said, and was echoed by by the others, women's health is community health. So we need to meet women where they are, removing barriers to inclusion in trials and to receipt of treatment. It's because women are such pivotal members of the community that their inclusion in trials requires compensation of the other roles they often take on, whether that's childcare or something else. And that pivotal community role is reflected in their predominance in the health workforce. And I think finally, I think Professor Zhang most strongly raised the solution that will be key to bridging the gap as demographic change occurs with the increase of non-communicable diseases. We need holistic, horizontal, and life course approaches to move away from our current vertical siloed approaches. So it's been really inspiring to see all the work being done to reduce the sex and gender-based inequalities in health research and care by these brilliant women and their teams. I hope you all feel as hopeful as I do coming out of this session that we will in time close the gap through multi-sectoral global efforts. With that, I'll wrap up. Thanks so much to our speakers for their engaging talks and to our attendees. Thank you.